We are very excited about today's presentations, and I would like to start off with our patient partner, Mr. Tom Weisz. So Tom is a retired chiropodist and podiatrist. He lives with type 2 diabetes, and he has worked very extensively with Diabetes Action Canada Foot Care Program. He works with Wounds Canada, Conference Board of Canada, and Diabetes Canada, and in the latter, he is the originator of foot care in the professional section for Diabetes Canada. So without further ado, I would like to hand it over to Tom to start our today's webinar.
Thank you very much, Tracy. Lovely introduction. One slight correction, if I may. It's the Foot Care Special Interest Group in the professional section of Diabetes Canada. There are a number of special interest groups, about a dozen or so, all of whom have obviously various areas of interest. So my personal story is actually not a terrible one. I was diagnosed with diabetes about 10 years ago. And I have my diabetes under fairly good control. My last A1C was 6.5, which gathers hurrahs and huzzahs all over the place. But I was working as a chiropodist in Ontario, podiatrist, and everywhere else in the world. And I saw an awful lot of what diabetes can and does do to people. I became interested in diabetic wound care well before I was personally diagnosed. When I was studying, I went back to study chiropody in my mid-40s, and one of our instructors, actually a couple of them, Bruce and Ted Hyder, brothers, were just superb instructors and were really into wound care. The wound clinic was actually run, the hospital wound clinic was actually run by Ted Hyder, as a chiropodist under the plastic surgery mandate. So I early on saw what diabetes can do to people, and it's a terrible thing when it comes to foot care. Of all the complications of diabetes, foot care is the most expensive. It costs the most. And it's by far the least thought about, researched, studied. We have an abysmal system of care. We don't even have a system of care at the moment. And after I was diagnosed and I was approaching my retirement time, I realized that if I ever developed a diabetic foot problem, the system of care required to give me optimal care simply did not exist, and unfortunately to a large extent still does not exist. So I decided that would be my retirement project to see what I could do about the system of care for the diabetic foot. Now, the simplest and most obvious way to take care of that problem is to get rid of diabetes. And that's what everyone else is working on. You know, God bless and more power to you all. But in the interim, I think I will keep beating on my particular issue in my particular way. I invite any and all feedback or input or help or spread the word or whatever else you can do. I could sit here and drown everybody in about 40 hours of statistics. I will spare you all that. But I will say that of all the things we need to remember is up to 85% of non-traumatic amputations in the so-called first world are secondary to diabetes. Up to 85% of those are preventable, and we're simply not doing it. all the pieces, all the knowledge, skills, capabilities, technologies, we have it all. It's all at hand. We just need to pull it together in some way or another. So that's what I'm doing. I welcome you to join the fight. Thank you.
Thank you so much, Tom, and we definitely appreciate you taking the time today to introduce our webinar series. We always have the opportunity to connect with our patient partners, including Tom. So if you feel that you would like to learn more about his work with Wounds Canada, Conference Board of Canada, or Diabetes Canada, you can always reach out to me, and I can forward you along Tom's contact. So thank you very much. We're going to be moving on, and I would like to take a moment to introduce our next speaker. Our next speaker is Frances Sobierajski. She has just completed her master's in the implementation of the Indigenous Youth Mentorship Program, and she's been working, and she's now a medical student for the University of Alberta. So I will ask her now to get her video started so that she can take it from here.
Thank you so much, Tracy. You guys can all hear me?
Yeah, we can hear you great.
Awesome. Okay. Great. Okay, all my slides are working. So hello, everyone. It's nice to be here virtually. I appreciate your time and enthusiasm for the topic. Today, I will be discussing the implementation of IYMP in year 1. I am presenting the PhD work of Sabrina Lopresti as she wasn't able to attend. I would like to acknowledge that today I am located on Treaty 6 territory and respect the history, languages, and culture of First Nation, Métis, and Inuit people. To provide context, IYMP is a communal, relationship-based after-school healthy living program. It's delivered by Indigenous high school students for elementary school children with the support of a young adult health leader chosen by the community. IYMP is guided by the teachings of Indigenous scholars Dr. Martin Brokenleg and Dr. Virna Kirkness. It has 3 components: a healthy snack, physical activity, and relationship building. IYMP is usually run once per week for about 90 minutes, and it's designed to be run for 20 weeks in duration. However, sometimes it's run from the start of September all the way until the end of the school year. At the time of this study, IYMP was being implemented in 7 communities. Since then, IYMP has rippled to more than 49. One of IYMP's objectives is the reduction of type 2 diabetes. Why is this the case? Indigenous people, including children and youth, are disproportionately affected by type 2 diabetes. The reasons for this are complex. However, it's clear that the intergenerational impacts of colonialism influence the health and well-being of Indigenous people. Therefore, strategies to promote the health and well-being of Indigenous youth require decolonizing strengths-based approaches. Therefore, IYMP promotes holistic wellness, prevents type 2 diabetes, and promotes positive mental health. It also aims to promote Mino Bin Matswin, the way of the good life. IYMP uses a community-based participatory research approach whereby schools partner with academic leads at a regional Canadian university to implement IYMP. We use a shared model of decision-making where community voice is prioritized at all levels. IYMP upholds OCAP principles, ownership, control, access, and possession, and supports school communities in making decisions regarding why, how, and by whom data is collected, used, and shared. Grounded in a CBPR approach, communities are co-researchers in all phases of the process. School communities have autonomy to tailor the program to meet their unique context. IYMP is relationship driven and builds on the strengths, energy, and talents of youth and communities. That means that the program might look different in each community because it's really truly being shaped by youth and the community. Research outputs are reviewed by both the local and national teams. Today, I will be presenting data from 3 studies used to inform the overarching objective of describing the characteristics of implementation, mostly in year 1. To achieve this objective, 3 research questions were developed. I'm going to go into more detail with these 3 studies in the next slides. To answer these questions, multiple data generation strategies were used, including both qualitative and quantitative methods. Data generation strategies included field observation, interviews, focus groups, and implementation logs. I'm going to describe the first 2 studies together as they were both qualitative in nature and use the same data analysis strategy of content analysis. To provide a little bit of context, content analysis takes interviews and transcribes them onto paper, and then the lead researcher is responsible for reading those transcripts multiple times to identify themes within the data. And those themes I will be presenting with you today. The first study explored the key characteristics of program delivery for youth mentors and YALs. What we found was that building relationships was at the center of program delivery. These relationships were noted at every level of IYMP, from community leaders to researchers to YALs to youth. This was an integral component of program delivery. Closely tied to relationships was communication and community engagement. Engagement with elders, traditional knowledge keepers, and other community members was important for sharing knowledge and was seen as necessary for successful delivery. Another important theme that emerged was instilling a sense of ownership. This was seen as important for ensuring program sustainability. Ownership was perceived to improve participant retention by improving self-esteem and feelings of responsibility. So an integral component of IYMP is having the program be youth-led. And finally, program supports, which included funding, training, manuals, and in-person gatherings to share information, were seen as essential for program delivery. The second study explored the essential characteristics of a multi-site community-university partnership with Indigenous communities, as perceived by IYMP principal investigators, both Indigenous and non-Indigenous. This study was very important to understand how IYMP was able to successfully develop a community-university partnership that spanned across multiple communities and multiple provinces. And so what made this partnership so successful? When we talked to principal investigators, what we heard was the importance of building a community of practice. And this community of practice was established on shared interests. PIs commented that everyone involved in IYMP was interested in Indigenous well-being and doing things in a good way with a good heart. They also identified, again, the importance of relationships and mentorship. Finally, decolonizing research approaches, which is grounded in awareness of colonial history and prioritizes community voice, was seen as essential. My apologies that I'm moving a bit fast, but we have included quotes on the screen to support each of the themes. The third study used descriptive statistics to understand what implementation looked like in 2 rural First Nations school communities in Alberta. So what did IYMP look like on a day-to-day basis? So we learned from these participant logs that sessions served choose most often foods most of the time, and those included fruits and vegetables. We also learned that physical activity was a very important component of all sessions, and the mean duration of physical activity at each session was 70 minutes. And most of that activity was vigorous intensity. We also learned that cultural infusions were embedded throughout the program. And what this looked like was different in every community, but some examples that I can share with you are in some communities that looked like sitting together, sharing a meal, building relationships. In other communities involved laughing, joking, cheering during games. And in other communities, it looked like sharing circles where y'alls asked participants what things like humility means to them. And so what did we learn from all of these studies? We learned a lot. And just to summarize a few points here, we learned that community voice should continue to be prioritized with an emphasis on decolonizing research approaches. We also learned, and I hope that I showed here today, the importance of relationships and forming a community of practice. With respects to day-to-day implementation, we learned that flexibility in local delivery and regular communication was essential, as well as community engagement, including elder knowledge keeper engagement, facilitated cultural infusions, and created local IYMP program experts. Before I take any questions, I want to thank our terrific IYMP team and also acknowledge the important contributions our funders provide to support IYMP. I'd also like to let you know that you can find more information on IYMP at katestory.com, and I can provide this link in the chat box. Thank you very much.
Thank you very much, Frances. Before we take any questions, I just want to thank you very much for coming here in today. I know the IYMP program is very important for Diabetes Action Canada just because it has seen such great successes. And actually, one question that I have just in hearing you about the scaling of the program is how many sites, if you can remind me, how many sites there are and how many provinces does this program take place in?
So currently we have 49 sites implementing IYMP, and we have sites in Alberta, Saskatchewan, Manitoba, Ontario, and Quebec.
Great. And of those, how many of those latter sites are from the recent grant that you received, the Pathways Component 3 grant?
I don't know that I can speak to that specifically, but there are quite a few that are from that most recent expansion.
Okay, thank you very much. Great to hear. So I'll give people just a minute to think if they have any questions with Frances about the IYMP. And if not, we will keep the question and answer open throughout today's webinar so that people, if it comes to mind as they're watching another presentation, can quickly type it in. So Frances will be here for the duration of today's webinars. So thank you very much. And already I see that there have been some congratulatory comments in the chat. So everybody seems to really have enjoyed today's presentation. So we're going to move on, and I'm just going to move the slides. Hold on a second here. There we go. And I'd like to introduce Bhavadharini Balaji as our next speaker. Bhavadharini did her master's and PhD training in India. She came to Canada in 2017, where she was part of the Population Health and Research Institute at McMaster University. She is a postdoc awardee with Diabetes Action Canada, working under Lorraine Lipscomb, who is a co-investigator with us. And she's currently working out of the Women's College Hospital in Toronto. So over to you. Oh, and you're on mute. I'm sorry.
Yeah. Okay. Sorry. Hi. Thank you, Tracy. Thank you so much to all the organizers for giving me a chance to present our work today. So the topic that I'm going to be talking about is my current work that I started a couple of months ago at WCH. And we're trying to understand if mobile health applications can be used to manage and follow up women with gestational diabetes. Gestational diabetes is a condition that affects about 1 to 14% of women worldwide, and it has implications for both the mother and the baby. In fact, there is about 7-fold increased risk of future type 2 diabetes for women who have had gestational diabetes during pregnancy. And in Canada, what we usually see is that many clinics do have a lot of a dedicated team, a dietitian, a certified diabetes educator, we have nurses, so all of whom come together to educate women about the consequences of GDM. And usually what happens is these women, once they're diagnosed to have gestational diabetes, are given glucometer, they're given diaries to log their glucose readings, and they're often advised to return to the clinic regularly to, during which time their glucose readings are reviewed manually, and treatment decisions are then made based on these data. Now, even in a very well-researched setting, we find that this kind of a model is pretty burdensome for both the physician and the patient. And what we intended to do was, through this project, we wanted to understand if there is a more efficient approach, to manage diabetes or gestational diabetes during pregnancy. And we thought one of the ways to do this would be by maximizing the current innovations that is there in the field of telemedicine or mobile health. And one such app that is already available in Canada, which has already been developed in Canada, has been used to assist adolescents with their type 1 diabetes, and the name of that app is BAND. So what we thought we could do was to, we wanted to see if we can use the BAND app to, So we wanted to see if we can evaluate the BAND app and, try and see if it would be feasible to use the same app to support self-management for women with GDM during pregnancy. And the specific objectives of this project is therefore to assess the healthcare provider and patient preferences using the BAND app, and also to identify potential gaps and opportunities, to enhance the app if necessary. And we hope to do this by incorporating various kind of data collection methods. We would be using structured interviews, short surveys, journey mapping, process mapping, to address our objectives. And one of the first things that we hope to do is first assess the needs from the healthcare provider perspective. And this we will be doing by conducting interviews and short surveys with healthcare providers. We will recruit healthcare providers from the Canadian Diabetes and Pregnancy Interest Group of Diabetes Canada. And this includes endocrinologists, we'll have nurses and dietitians who are usually involved in the care that we provide for women with GDM. And so they will be asked to provide feedback on, the current care context and how they, will be using the input and feedback that we receive from these physicians will be, useful to develop our project further. The second thing that we hope to do is to assess the needs from a patient perspective. And before we assess the needs from the patient's perspective, we would first be recruiting patients as patient partners, and we'll be engaging them in our patient partner engagement discussions and meetings, where we'll be asking them to share with us their lived experiences, about how they've been able to manage GDM. Right now with the COVID, almost all the healthcare that is being provided to women with GDM is through virtual care. So we would want to understand from patients through our patient partner engagement meetings. We'll be able to understand from them how their experience has been before COVID and currently during COVID, and how the virtual care that they've been experiencing so far has been, how it's been helping them so far. And after we do that, we will initiate the study where we will be inviting women, pregnant women, to use the BAND app, and we'll be getting from them their opinion about the BAND app. We'll be evaluating their perception, their acceptability, and how they find the app useful and all that through semi-structured interview guides. And we'll also be collecting these patients' clinic data in 3 months before and after for understanding more about these patients. Right, so we will also have, as I mentioned, patient partner engagement, and we will also ensure that patient partners who are, engaging with us in our project will be representing a diverse population, and feedback, about the project and the results that we have from the project will also definitely be communicated to patients. So I've been doing this work since September last year, since I received the fellowship from DAC. And so far we've been able to complete a certain, we've been trying to, follow, physicians and patients at the Genome Clinic and try to understand their interaction. I've also been able to, set up meetings with our collaborators to discuss about patient partner collaboration. We have plans underway right now to identify patient partners to form a network, and we'll hopefully be soon starting the work by engaging patient partners once we have them on board. We're also currently working on other apps other than BAND app. We're trying to understand if we have similar mobile health applications which are diabetes specific, and if we can use them for this project. So that is all from me for today, and over to you, Tracy. And I would really like to thank the DAC for giving me an opportunity today to speak with all of you. Thank you so much.
Okay, and thank you. So there are any questions for Bhavadharini? If you could please put them in the question and answer rather than the chat, because we aren't monitoring the chat as high, and we're just trying to make sure everything is consolidated in one space. But before we get started, I actually had some questions about the BAND application that you're going to be using. And I'm just wondering, how far along are you in the developing of the app?
So the BAND app has already been developed. So we haven't developed the app ourselves. We have a couple of our collaborators, I think at UHNs. They have developed this BAND app, and it's already been studied, and the use, the acceptability, all of that has already been studied, but not with pregnant women. They've been testing the app with adolescents with type 1 diabetes. So we're just trying to see if we can use the same interface and see if we can use this, because it's diabetes, and it's, at the end of the day, it's all blood glucose monitoring and SMBG and all that. So we're just trying to see if we can use the same app and understand from a woman with GDM if we can use the same app for them.
Great. And I should have answered, structured my question a little better, just to let everyone know that the BAND app is actually a very important aspect of Diabetes Action Canada, and we have it available as a diabetes self-management opportunity for people living with type 1 and type 2 now. So there is an opportunity for people who are interested in having more data about tracking their diabetes to use this application, and it's on all of the application download centers, Apple, Samsung, and so on. So I'm guessing that it's not going to be modified in any way then for your purpose.
For now, yes. Yeah. Until we, get the feedback from patients, we don't really want to jump into modifying the app right away, and that's why we have the patient partner engagement, we're going to start that pretty soon, hopefully in the next couple of months, to understand from them if this is what they really want, before we jump into asking, before we modify something, we want to know if that is what they really want to use. So that's the plan.
Okay, great. And I see that there is something there in the chat. If you could just respond with your contact
Sure.
information, because I
I'll
think
do that.
that's great. I
Thank
do have
you.
a question
Sure.
here about the BANT study, and it says, how would the first two parts of the study influence, i.e. interviews and surveys from physicians and patients? And the third part is, which is the usability testing part?
So the thing is with the project is still ongoing. None of what I've presented so far, I have not presented any results because we haven't really got any data so far. So this is in progress. So we are still waiting to implement or disseminate our physician survey. We're planning to do it online. And even our patient partner engagement, we will have to stick to doing it through virtual things. So it's all in progress, and none of this is actually yet complete.
Okay.
And I hope to get this done by, before the end of next year. So yeah.
Excellent. Well, we look forward to seeing it.
Thank you. Yeah.
Yeah. Okay. So thank you very much. And we will move on. Would like to introduce Francesca Brundisini, and Francesca comes to us as a member of the Quebec Sport Support Unit and a postdoc with our KT research group, which is led by France Legoret and Maud and Leberge. She did her master's in Italy and her PhD in health policy at McMaster. So without further ado, I'm going to pass it over to Francesca, and I'm just going to make sure she's all set here. Oh, there she is. Okay.
Okay. Thank you very much, Tracy. Hello, everyone. It's great to be here today. First, I want to thank Tracy for the lovely introduction, and also Ron and everyone at Diabetes Action Canada for putting together this amazing online webinar series. And thank you all for joining to this session today. And I look forward to your comments and feedbacks at the end of the presentation. Before I begin, I also want to acknowledge, since I'm calling in from Quebec City today, I want to acknowledge the privilege we hold here in Quebec as we live on the unceded territory of the Huron-Wendat people, and I want to thank them for this privilege. So to turn to my presentation, first of all, I'm presenting on behalf of my whole team, and I want to also thank them for all the collaboration and help they have given me throughout the whole research project. And today, my topic will focus on how knowledge exchange of primary care research can benefit diabetes individuals. So what do we know so far about knowledge exchange of primary care research? We know that mobilizing knowledge about diabetes care across different settings can improve diabetes management. However, we also know that primary care research findings are not automatically used by its users in everyday practice, where its users are both the health professionals and the citizens. We know that up until today, there are strategies that address the gap between research and health professionals, but little is known about effective strategies for disseminating and exchanging knowledge with the general public. So, okay, I don't know if I did that, okay. So, and we think that developing these strategies and we think that there is the need to explore these strategies even more, especially in this day and age in which people are increasingly subscribing to online misinformation and fake news. So we believe that providing primary care research outcomes in a trustworthy and safe environment outside also of the clinical settings, such as in public libraries, can help people living with diabetes manage their health and make informed decisions and become as well, let's say, ambassadors of this information, as they can pass on this knowledge within their own communities and within their own families and friends. So we then decided to take these activities out of the clinical settings and into public libraries. And we designed these public libraries citizen workshops as a knowledge dissemination and exchange strategy aimed at raising awareness and informing the public in public settings. We devised these citizen workshops as a team together with a patient partner, researchers with expertise in patient-oriented research, a healthcare professional, two public library officials, and a science communication specialist. Together we designed the aims, the content, the format, and the settings of these citizen workshops, which were divided in two parts. There was a first 45-minute presentation on the topic of potentially inappropriate medications among elderly. The 45-minute presentation facilitated by a healthcare professional and a science communication specialist. And this presentation also included an embedded video of our patient partner sharing her experience and her knowledge about the topic at hand in the workshop. This 45-minute presentation was then followed by a 45-minute knowledge exchange session where the participants, so adult citizens, the science communication specialist, and the physician discussed and shared their opinions, their insights about the topic at hand. We explore what knowledge the citizens, the physicians, and the science communication specialists value and understand as knowledge in these citizen workshops conducted in public libraries. So the findings will support the knowledge exchange in public settings and as well advance research of knowledge exchange practices with diabetes citizens. At the same time, we believe that by identifying and describing this knowledge, we will help build also a shared understanding among those who hold different views. Okay, next slide. So to answer our research questions and address our research objective, we adopted an interpretive description approach, which is grounded in pragmatist epistemological traditions, and it is described by Sally Thorne. This approach enables to descriptively explain a phenomenon to generate knowledge that is useful for policy and practice, and this is the reason why we selected this approach. We collected data from the informed dialogues during the knowledge exchange sessions of these citizen workshops. So after the PowerPoint presentation, the dialogues were recorded, transcribed, and then analyzed using a two-staged iterative and inductive thematic analysis, similar to grounded theory. Overall, there were 278 citizens, 18 physicians, and 6 science communication specialists that participated across 22 citizen workshops in public libraries in Quebec City and Montreal in the months of April and May last year. Of these citizens, 278 citizens, most of them were of the age of 64. Most of them were women and have completed a post-secondary education degree. Next, please. So the patient partner's contribution and support to this project was very valuable, and she provided the support throughout the whole research process, from the beginning and the design and the content of the workshops. And as I mentioned before, she also added her own video within the PowerPoint presentation. And we were actually discussing of having her feedback on the findings of our analysis and hoping that she provides insights about the citizens' beliefs and perspectives. And she will also contribute to the future design of a workshop session with the public to inform about the findings of the study. Finally, citizens also collaborated in the workshop dialogues as active participants, as they contributed to sharing and also to eliciting their thoughts, and also the healthcare providers and science communication specialists' thoughts about the topic that they were discussing during the workshop session. Next slide, please. So our analysis identified these 4 different types of knowledge that participants valued and co-constructed during the citizen workshop knowledge exchange session. We identified knowledge as biomedical knowledge, as sociocultural beliefs, as value-based reasoning, and institutional knowledge. Biomedical knowledge included scientific evidence and as well as research production and products, epidemiological and practice guidelines, and pathophysiological theories. Physicians and science communication specialists tended to prioritize this type of knowledge. However, they also acknowledged the limitations of, let's say, scientific evidence, and also highlighted the value of using other forms of knowledge listed on this slide. Citizens valued biomedical knowledge as well. However, during the dialogues, what they highlighted and emphasized more than once was the lack of access to this type of knowledge. Participants also discussed knowledge as sociocultural beliefs, which are socially and culturally, let's say, defined assumptions that are assumed to be true, but without, let's say, any form of evidence, and usually derived from personal experiences and localized experiences. Physicians and social and science communication specialists discuss their beliefs in innovative clinical practices, such as deprescribing and latest shared decision-making practices, while citizens actually share their beliefs in over-medication practices, anti-medication, and sometimes also their personal beliefs about physicians' behaviors in the clinical setting, especially when prescribing medications. At the most abstract level, the participants, all of them, discussed a knowledge also based on values, where values are preferences, needs, and wishes. And they addressed both patient-related values as well as healthcare provider-related values. Overall, values of patient empowerment, patient autonomy, fair participation in the decision-making process, transparent access to knowledge, patients' trust in the healthcare providers, as well healthcare providers' credibility and accountability, were all discussed as shaping and influencing their way of thinking. Finally, participants discussed knowledge also as the different roles of institutional actors, as well as their roles and responsibilities and their relationships between them. These institutional actors are the healthcare profession, the government, the insurance and pharmaceutical companies, as well as the market more in general. They discussed in particular the knowledge about the healthcare system and how to navigate it, as well as to how to overcome systemic and economic barriers to accessing knowledge and healthcare. Next slide, please. These findings help to understand then how citizens, science communication specialists, and physicians take stock and discuss knowledge during these public library citizen workshops, which will then contribute, on one hand, to advance citizens' awareness and knowledge to support better self-management of diabetes care, as well as to advance horizontal mobilization of knowledge among citizens. This is what I was talking about before, that they will become ambassadors themselves of the knowledge that they learned during these sessions in these public settings. And the other takeaway message is that knowledge exchange includes other forms of knowledge beyond explicit and formal research outcomes, and usually this knowledge comes from personal experiences and shared understandings. So these findings can then help inform future research on knowledge exchange practices that address a larger public in public settings by helping to build a shared understanding of what type of knowledge is valued and used in public knowledge exchange practices. Next slide, please. So we believe that this study offers a number of valuable lessons that can be used to improve also future research. First of all, we believe that the patient-partner collaboration and support added great value to the design, implementation, and knowledge dissemination. This will be happening this fall, I hope, of the research findings and of the whole research process, by providing key insights into the whole research process and findings. And the second important lesson is that public library settings also allow to shift the boundaries between the scientific and the localized personal understanding of knowledge, creating instead this open space for dialogue and negotiation. However, as we know that knowledge exchange activities with the public are actually very new and mostly unexplored, we do also acknowledge that there's still room for improvement. And by looking back at the whole project, now we think that we could have done some things differently. First of all, we believe that patient partners should have maybe contributed to the analysis of the data. We believe that the patient partner could have strengthened the analytical sensitivity and richness of the findings. And another limitation of the study is that it's not limited to diabetes individuals, but it's like geared towards a wider public. But we still believe that these findings are valuable for improving knowledge exchange practices, also with diabetes individuals in non-clinical settings, and therefore play the role of like a springboard for future research of knowledge exchange practices in public settings targeting diabetes citizens. And finally, this is something that came up recently. We are thinking about also how the current COVID situation has changed since we started the study last year, so before the whole COVID pandemic. and the new, let's say, emergency measures of social distancing that limits in-person social gatherings. So we've been thinking about also like how does this change also, and what kind of impact it has on the findings. And we think actually that this is our study and the current situation can also create new opportunities to re-envision the role of public libraries that continue to be, let's say, trustful sources of knowledge. And so this means that there are still growing opportunities to make public libraries a safe and trustful environment where citizens can go and learn the latest research findings. And this is all. Thank you very much for your attention. I'll be happy to answer any questions you might have.
Okay, thank you very much, Francesca. We're happy to take any questions, and I will actually take a moment to ask my own. You mentioned it actually right at the end about how you've had to pivot the findings of your studies due to the COVID-19 pandemic, and I just have a question about your response to that. When you mentioned the use of public libraries, are you considering them to be in-person public libraries or virtual?
So the point, originally it was in person. So we started this project last year, so when COVID was still not an issue.
Right.
And our belief was that since there is we're in this age of like fake information, fake news and all that. So we wanted to take information out of like offline and in person. And the public library is one of the most trusted, let's say, sources to gain knowledge for the public in general. So, but the COVID has changed this, but this doesn't mean that it's let's say, disadvantage. It can still be an advantage to develop, let's say, online virtual programs.
Mm-hmm.
And utilizing still the public library as a place to host these online programs in the future.
Mm-hmm. I only ask that just because people who live with—
Does that answer your question?
Well,
okay.
It did, and I have a follow-up, and then I see there's another question here in the chat, so I'll take it. I just wanted to interested to know, because I know not specifically diabetes, but anyone with chronic conditions might be a little apprehensive to do anything in person, even on the coattails.
Right.
Pandemic. So I wasn't sure if there was going to be a hybrid model in person versus a virtual opportunity.
Well,
oh, I think you're freezing.
This is something that we should definitely explore. Yes.
Okay, fantastic.
I think there's a lag. Yes.
Okay, so I just have one more question coming through on the chat.
Yes.
Can you comment on the fact that the majority of your participants were educated women?
So this is also something very interesting, and something that also other team members discussed about is the fact that obviously, first of all, I can talk more about the educated aspect of it, because it might have been due, since the participation was voluntarily, this might have been due to the ways we advertise these workshops. So they were advertised on different channels, on, for example, radio stations that usually actually target older, educated types of audiences. The other reason is because probably this type of educated people might be more, let's say, somehow more also self-aware of their own condition, and so also more receptive to these kind of events and these kind of workshops. The woman still, I haven't addressed that personally, and any insight from anyone also in the audience will be much appreciated. But generally speaking, I'd say that women are more self-aware of their bodies. And so I might think that that's one of the factors that go into why we had this kind of audience in these settings. And the other reason also is that it was geared towards elderly populations. So it was on the topic of potentially inappropriate medications among the elderly. So maybe that have contributed to this type of audience as well.
Right, excellent. And it says here that as a follow-up to this question, it says here the reason why we're asking is that City Hall tells us that libraries are attended by citizens of low socioeconomic status, which is great in terms of potential reach.
Right, that's true.
Well,
Yes,
that's true, yes, okay.
no, great observation.
Okay. Well, thank you very much, Francesca. And I just want to take again an opportunity to really thank everybody in today's webinar. Again, we had a great introduction from Tom Weisz, and I want to thank Francis, Bhavadharini, and Francesca for their excellent talks. All of these people are available for follow-up comments and questions if you feel you have anything that's come to mind. So thank you very much. I also want to thank our co-host here, Ron Boleno. He always works in the background. He is a patient partner here at Diabetes Action Canada, but also super handy with the Zoom and the post-Zoom editing. So thank you again, Ron. We are going to be having this on our website shortly. We'll get the recording and posted very soon. So again, it will be available for further watching. And our next webinar is going to be on September 30th. And it again is an extension of the training and mentoring. We really wanted to highlight all this fantastic work that our trainees are up to. We don't often get an opportunity to do this because we have so much research happening within our network. So this is a great way to highlight some of these excellent projects. So thank you again for your participation. And signing off again, my name is Tracy McQuire and I moderated today's session. So looking forward to seeing you next time.